Hello everyone. Today we are going to learn about a premalignant white lesion called leukoplakia. So starting with the definition, leukoplakia is defined as a whitish patch of plaque that cannot be characterized clinically or pathologically as any other disease and is not associated with any other physical or chemical causative agent except the use of tobacco. By definition itself, it is clear that leukoplakia can be diagnosed only on the basis of the history that the patient has been consuming tobacco. Coming to the classification of leukoplakia. So basically there are two types, homogeneous and non-homogeneous type of leukoplakia. In homogeneous, the various appearances are flat, corrugated, pumice-like and wrinkled. In non-homogeneous, the appearances are described as verrucous, proliferative, nodular and speckled. We'll be seeing the pictures in further slides. Coming to the etiology, as I've already mentioned, the principal etiology of leukoplakia is consumption of tobacco. The predisposing factors could be alcohol, chronic irritation, candidiasis, syphilis, vitamin deficiency, certain nutritional deficiency, xerostomia, viruses, and it could be idiopathic. Now, the malignant potential of leukoplakia depends on its appearance, site, and etiological factors. It has been proven that the non-homogeneous type of leukoplakia has more malignant potential than the homogeneous type. Now, these are the various appearances of homogeneous leukoplakia. We can see here, ebbing type of pattern is seen here in this case. This is the classic appearance of leukoplakia called as the cracked mud appearance. Like the appearance is of mud which is dry and cracked. Similar appearance can be appreciated in the lesion of leukoplakia. This is the typical appearance of homogeneous leukoplakia. This is the speckled variety of leukoplakia. Here we can see specks of white areas are seen in the base of red area. Coming to the diagnosis, usually the clinical examination and the appearance is very typical of leukoplakia along with the history of tobacco chewing. But to be certain, we can definitely go for a biopsy. Toluidine blue test can be done to identify the proper biopsy site. Oral brush biopsy can also be taken. Certain biomarkers are important to identify the malignant changes. 2 to 5% of leukoplakias may become malignant over a period of 10 years. 5 to 20% of leukoplakias are dysplastic, and 10 to 35% of leukoplakia with dysplasia may lead to carcinoma. Now, coming to the differential diagnosis of leukoplakia, the first and foremost differential diagnosis is lichen planus. But the principal factor of tobacco chewing will be absent in lichen planus, whereas it will be present in leukoplakia. At the same time, lichen planus is more common in females, and the lesion is mostly bilaterally present, whereas leukoplakia is usually seen in the area of tobacco keeping or quid keeping habit. Second DD is candidiasis. Candidiasis, if it is pseudomembranous type, which will mostly mimic leukoplakia, will be scrapable, whereas leukoplakia will be not. These two are the most common DDs of leukoplakia. Coming to the treatment modalities, as I've already told, that tobacco is the principal causative agent for leukoplakia. So, firstly, we have to ask the patient to stop the habit, smoking or non-smoking, whatever form the patient is consuming tobacco. You have to remove down all the sharp, broken down teeth. You have to replace the faulty metal restorations and metal bridges if there are any. And you have to eliminate other etiological factors like syphilis, consumption of alcohol, and so on. Coming to the proper treatment of leukoplakia, after you have eliminated all the irritants, we have to advise patient for usage of topical antifungals for 1 to 2 weeks. The most common preparation uses clotrimazole. You have to eliminate habits like tobacco and alcohol. If the lesion is not responding to the treatment or the lesion is very big, we should go for biopsy. We can also go for systemic vitamin A therapy, 13-cis retinoic acid, tretinoin, cryosurgery, laser surgeries can be done on bigger leukoplakic lesions, and certain topical anti-cancer drugs can be given, like bleomycin, methyl sulfoxide, etc. Now, there's a variant of leukoplakia called as the erythroplakia. As the name is suggesting, erythro is red, plakia is patch. Erythroplakia is defined as a bright red velvety plaque or patch which cannot be characterized clinically or pathologically as being due to any other condition. Erythroplakia has a very marked malignant potential. Although the etiology of erythroplakia is uncertain, Mostly the cases of erythroplakia are associated with heavy smoking with or without concomitant alcohol abuse. Coming to the clinical features, the homogeneous type of erythroplakia, this appears as a bright red velvety soft area on oral mucosa with an irregular but well-defined margin. Erythroplakia interspersed with patches of leukoplakia. This is the another clinical variant of erythroplakia. In this type of lesion, there is presence of multiple irregular erythematous areas, and at the same time, there are few white leukoplakic patches also present. Third clinical variant is the speckled erythroplakia. These lesions are similar to speckled leukoplakias and are characterized by presence of soft, irregular, raised erythematous areas with a granular surface. These lesions have few white blast distributed over the surface. Erythroplakia usually occurs in older men around 6 to 7 decades of life. Erythroplakias are most commonly seen on the floor of mouth, ventral surface of tongue, soft palate, tonsillar fosses, and all prime areas which are for the development of carcinoma. Sometimes multiple lesions can also be present. Almost all of the lesions are asymptomatic, but sometimes burning sensation may be present. The DDs, the most common DD of erythroplakia is erosive lichen planus because it appears very similar. But Wickham's try will be present in lichen planus, which will be absent in case of erythroplakia. Plus, as I've already discussed, lichen planus is usually bilaterally present. Treatment: the lesion should be observed for 1 to 2 weeks after the elimination of suspected irritants. After that, again, toluidine blue staining can be done on red periods, and then biopsy can be performed to rule out any dysplasia. So this is it about leukoplakia and erythroplakia.